Welcome to Derms on Drugs, a video podcast brought to you by Scholars in Medicine, the best educational platform in dermatology. And Scholars in Medicine happens to be a no-cost offering for healthcare providers. All you need is an NPI number, and you are able to access the hundreds of hours of educational content that is coming from the best lecturers in the world. Derms on Drugs is where cutting-edge derm meets hit-or-miss comedy. I'm Matt Zyrus, and each week I'm joined by my residency buddies, Dr. Laura Ferris and Dr. Tim Patton, to use our 60 years of combined experience to discuss, debate, and dissect the hottest topics in dermatology. It's everything you need to know to be on the cutting edge of derm, and it'll be the most fun you've ever had while learning something useful. New episodes drop every Friday on Scholars in Medicine, Apple Podcasts, Spotify, and wherever else you might get your podcast content. So this week we've got one of our patented six-packs where we are going to discuss the 6 topics or articles that we found most interesting in the last couple of weeks. In the same way we'd sit on the back porch and discuss them over a six-pack. So we are going to get started off right away with Dr. Ferris. Dr. Ferris, what do you got?
Thanks, Cyrus. So my first paper is from Annals of Oncology, Grover et al., and this is efficacy of adjuvant therapy in patients with stage 3A cutaneous melanoma. So this was a multi-center retrospective study, okay, for patients with stage 3A melanoma that's using AJCC8 staging who received either adjuvant PD-1 inhibitor, so pembrolizumab or nivolumab, or the BRAF/MEK targeted therapy, dabrafenib, trametinib, or did not receive any adjuvant therapy and were just treated. And so what
Ferris, remind me.
I'm sorry, we're just observed. Yes,
remind me. There's neoadjuvant, adjuvant, and then rescue.
So there is neoadjuvant therapy is I give you your chemo or immunotherapy, then I do your definitive treatment, which is surgery. And then adjuvant is I remove all of the tumor surgically, and then I give you the treatment to try to prevent recurrence. And then there's also, primary treatment of like metastatic disease or unresectable disease, but we're not talking about that. So we're talking about stage 3A patients.
So adjuvant specifically means you think all the cancer that you are aware of in their body is gone, and you're giving them chemo because there's a good chance there's some in there that you just can't see.
There's some chance. So basically, what I'm trying to do is prevent you from having a recurrence of your disease or from having your disease metastasize. And ultimately, my goal is to prevent you from dying of melanoma because it returned or metastasized.
And I know we're talking about 3A lesions here,
Yep.
So these would be people who don't have a lymph node. But let's say you had a...
They do. So just a quick review. Who's staged? Okay. So who is this patient? You biopsied their tumor. They had, let's say, a T2A melanoma. They had a sentinel lymph node biopsy, and it was positive. Okay, but it is a small, microscopic disease, and it is one node, and it is, it's sort of the earliest lymph node involvement that you can have. So it's detected just through sentinel node biopsy. You had your sentinel node, you had your resection of your primary tumor. Now what do? You can get a treatment, or you can just undergo observation.
Okay. Have they had that lymph node basin cleared out? Or
so in some cases, because this is a retrospective study, in some patients they did have a therapeutic lymph node dissection. That is not standard of care now. If you have a positive node, you do not get a resection of the lymph node basin based on data from MSLT2.
Okay.
So
all right. All caught up now. Okay.
Okay. There we go. Oncology 101. Okay. Reviewed. All right. So we know, so what is the prognosis for patients with stage 3A melanoma? If you look at their, 10-year melanoma specific survival, it's 88%. 5-year melanoma specific survival, it's 93%. So most patients are not going to die of melanoma. Now, by contrast, if you look at a patient who has, let's say, stage 3C disease, their 10-year melanoma specific survival is 60%. So big difference, right?
What's
Even
3C
stage
mean?
3B. So let's
What's
say
three?
3B, it's 77%
What do B and
versus.
C mean?
So those are patients who basically have either like thicker ulcerated primaries and or multiple nodes or more. They have basically sort of a bigger burden of lymph node disease.
Okay. All right. Got
Okay.
it. Okay.
All right. We don't really know a lot about stage 3A patients. Why? They were limited in the prospective clinical trials that were done looking at adjuvant therapy because they are lower risk, right? If the risk of recurrence is low, so they limited the number of patients to so they're kind of underrepresented. So we don't have a lot of data on them too. If you look at some of the earlier staging, it was done under AJCC7. And so patients, staging changed a little bit with AJCC8. So the thought was here, let's try to get some more data by sort of aggregating, doing retrospective studies of patients treated, not in a clinical trial setting. And so they have 628 patients, all who have stage 3A disease, 34 centers across the US, Europe, and Australia. And so there were, of those 628, 256 had PD-1 adjuvant therapy, 80 had targeted therapy, so BRAF/MEK inhibition, and 292 were observed. So I like that there's sort of that control group of the group that got nothing. Median follow 2.6 years, median duration of treatment about 10.2 months in both groups. Okay, endpoints were recurrence-free survival, distant metastasis-free survival, and toxicities. So what were these tumors? Median tumor thickness was 1.3 millimeters. Okay, so sort of an intermediate thickness group. If you look at the melanoma, nodal deposits, so in about 60% of patients, it was less than a millimeter, and in about 40%, it was greater than a millimeter. So just to give you an idea, of course, the only group that would be eligible for targeted therapy are those who have BRAF V600 mutations, and that was 40% of the population. And then the most common, and then they looked at, what were the most common reasons for discontinuation? It was toxicity, a little bit higher in the targeted therapy group, 21% in that group versus 13% in the PD-1 group. Now, this is a retrospective study. So what you didn't do is randomize them. So there's going to be likely some differences between the groups. So, one of them was age. If we look at patients who had observation, were older than those who had PD-1 treatment, who were older than those who got targeted therapy. Ulceration, lymph node mets greater than a millimeter, and median node diameter being larger, so all higher risk features, were seen more commonly in the PD-1 group than in the targeted therapy group, than in the observation group. So kind of the patients with the worst disease were tended to be put on PD-1 therapy. And then to your question, Matt, about completion lymph node dissection, because some of these were done prior to MSLT2 data, there are patients who had that. That was more common among the PD-1 group, and then which was more common than the observation group, which was more common than the targeted therapy group. Okay, so little
Got it.
differences here.
Okay. Were they able to control for all of it? Is that stuff you can control for and do statistical mumbo jumbo, which we don't quite trust, but it's better than nothing, or it's just like, okay, they're different. We got to keep that in mind.
You can, and they looked at that a little bit, but mostly they really just kind of reported out the 2-year recurrence-free survival, which is,
All right.
I think, where you get the most important data. Okay, so if you look at local, regional, or distant recurrences, it was 23% of the patients in the PD-1 group, 1.2% in the targeted therapy group, and 18.5% in the observation group. So actually a pretty significant difference between the targeted therapy versus observation. But remember, the higher risk people were the ones who got PD-1. I'm sorry, so more recurrence in the PD-1 versus the targeted therapy, but the more severe patients got the PD-1. 2-year recurrence-free survival was 79% for the PD-1, 98% in the targeted therapy, and 84% in the observed group. To your distant metastasis-free survival, 88% in the PD-1, 100% in the targeted therapy, and 91% in the observation.
So the PD-1s almost look worse than observation, but they were not the same people who got observed versus who got PD-1'd.
Right.
So the PD-1 people had a much higher baseline risk, so we don't know for sure, like,
we have to remember that they're not equivalent groups. So where was this sort of difference statistically significant? Recurrence-free survival and distant metastasis-free survival between targeted therapy and observation, and targeted therapy and PD-1. So targeted therapy looked better than both observation and PD-1.
So if you've got a BRAF mutation, do they do them together ever where you get the
They do, but not in the adjuvant. I mean, there are trials looking at that, but not in the adjuvant setting. Okay, so not in these patients who don't have any known disease. So if you just look at, so remember, only the BRAF mutation patients are eligible for targeted therapy, right? So if you just took that group, they did have a statistically significant improvement in recurrence-free survival and distant metastasis-free survival relative with targeted therapy relative to anti-PD-1 or observation. So even just that subgroup that could have had any of the treatments, they still did better on targeted therapy. If you took the group that did not have BRAF mutations, there was no difference in RFS and DMFS when you compared PD-1 and observation. So there really wasn't like a lot of great evidence for the value of PD-1 therapy. So treatment-related adverse events, more common in the targeted therapy group, like 77% of them versus 53% in the PD-1. But if you look at the kind of, adverse events that lasted for greater than 12 weeks, that was more common in the group that got immunotherapy. And we know that tends to be the case. For all groups, most common toxicity was cutaneous, so rashes. Most common grade 3 or higher, like the bad toxicities in the PD-1 group, was colitis, and in the targeted therapy group was fever.
All right, Ferris. So you, Dr. Laura Ferris, wake up tomorrow and have a 3A melanoma.
And I've got it, and it's BRAF mutated.
It's BRAF. No. It's no BRAF. If it's BRAF, you're obviously going to take the targeted. If it's not BRAF, and your choices are observation versus immunotherapy, what are you going to do?
To be honest, with a 3A, I'm probably going to do observation. Because one, the benefits.
I would get Castle testing, and if it was bad, I would get the PD-1, and if it was class 1A, I would do observation. I was mean to Castle in one of our more recent episodes. Theoretically, this could be one of these areas where, yes, this could help us.
Okay. Cool. There you go. Okay. So maybe there is. Now, I think you'd want little data to support that, but yes. So I thought that this was interesting. I think that there probably is some, bias into who got PD-1. So there's a very important therapeutic study for patients in like unresectable stage 3 or stage 4 disease, called DreamSeq, where they were randomized to either get immunotherapy, and then when they when they progressed, then they went on to targeted therapy, or they got targeted therapy first and then they switched over to immunotherapy if they progressed on that, right? So it's like, should you start with one over the other? And the group that got immunotherapy up front did way better than the group who started with targeted therapy. So this was, I think, like a lot of people would have thought, like, oh my gosh, you should always, if you got a choice, you go with immunotherapy. But this is kind of interesting because it shows that, there was, that the group seems to do a little bit better. But, the author said, while the data show targeted therapy on face value looks to be better, that we should caution recommending one over the other, given the relatively low number of patients in the targeted therapy group, 80 versus 195 in the, in between the other two treatments. And then modest median follow-up, and only one recurrence was seen in the targeted therapy group. So, I think this is really interesting,
Okay.
but I think, to Dr. Patton's point, you got to think about, to me, this was like, gosh, what do you do with the 3A patients? And, maybe this is a place where GEP could be helpful. There's some people who are going to recur, most are not. And so to think about giving these, expensive and, therapies with a lot of toxicity, if we really could pick out those few that might benefit from it, that would probably be really, really helpful. So I thought this was really interesting.
Okay.
It's totally interesting, right? I mean, it's like, what do you do? I don't know how these oncologists decide. That'd be a tough visit.
That's why we're dermatologists.
Yep.
All right, Patton.
Do I pop this pimple? Do I not pop this pimple? Do I observe it? I don't know.
I just give targeted therapy to it. It's good.
We're going to targetedly pop that pimple, not the other one. We're not going to target the other one. All right, Patton, what do you got?
All right, my first 6-pack was published online February 2025. It's from JAMA Derm, and it's titled Patterns and Clinical Implications of Misdiagnosis in Dermatomyositis by Bao et al. This was a single-center retrospective cohort study conducted at the Johns Hopkins University. Quick plug, Ferris and I were smart enough to attend Hopkins for our undergraduate training, and Zyrus was not.
No, I was there for graduate school. I was not smart enough to go as an undergrad.
Oh, I was the only one smart enough to go.
Only one.
Graduate school is probably harder.
Well,
Wait a minute. But that Johns Hopkins led to a prestigious DO education. Jeez.
Ouch. That's a good one. Can we edit that out? The authors wanted to focus on the fact that DM is often misdiagnosed, so that they wanted to ask what it is often misdiagnosed as, and they wanted to compare DM versus clinically amyopathic. That's what CADM stands for, clinically amyopathic dermatomyositis.
Yep.
I swear, every time I see it, I want to say cutaneous only dermatomyositis. And I can't get away from that. Clinically amyopathic dermatomyositis, in terms of misdiagnosis, they wanted to see what the clinical implications of misdiagnosis were. So they looked at cases of DM diagnosed from 2005 2023. They had 260 patients, 260 DM patients. 36 patients were misdiagnosed. There was a way that they came up with that. I didn't want to get into that. Just could go straight to the numbers. We could talk about that if you want, but a higher percentage of clinically amyopathic cutaneous Anley dermatomyositis patients were misdiagnosed compared to DM patients. So again, just higher percentage of clinically amyopathic DM patients misdiagnosed compared to DM. And it took longer for the CADM patients to be diagnosed compared to DM patients. This was all at the bottom of table 1. Short paragraph that was kind of confusing. So the most frequent inflammatory skin disease diagnosis in the dermatomyositis cohort were derm NOS and eczema. That's not too surprising. Overall, cutaneous lupus must not have been as frequent an inflammatory skin disease, but CLE represented the highest rate of misdiagnosis. So as my guess, there were only like 3 patients in the cohort who were diagnosed with CLE, and 2 of the 3 patients had their diagnosis changed to DM. So it was like 67% of patients who had that diagnosis of CLE eventually wound up being diagnosed with DM, even though it was a smaller overall amount. That was kind of the way I teased that out. They didn't like have a table specifically of those numbers. So that's it. Table 2 compares misdiagnosed patients with diagnosed, and the differences that reached statistical significance were overall hospitalization rates within 1 year of dermatodiagnosis, onset of interstitial lung disease within 1 year of diagnosis, and lower diffusion capacities at the time of ILD diagnosis. There wasn't a significant difference in any of the cancer numbers, like, at what stage of the misdiagnosed versus diagnosed. Those numbers were about the same. So the lung disease is probably what seems to be the most important clinical aspect of what goes wrong when you misdiagnose these patients. They seem to have worse lung disease when that's finally diagnosed. So maybe earlier diagnosis, institute earlier treatment, that actually maybe prevents the lung disease from developing. I don't know.
What about, so clinically amyopathic patients are at higher risk of worse interstitial lung, or higher risk of interstitial lung disease than
Yeah,
clinically myopathic, right?
well, that's what I always learned. The overall rates of interstitial lung disease between clinically amyopathic versus dermato were about the same. That was in table 1. They kind of broke that down. Yeah, so I was surprised at that. I think way back when we were residents and we talked about malignancy risk, don't you remember at first, like if it was clinically amyopathic, you didn't have to worry about malignancy as much, or am I misremembering that?
I think you're misremembering that.
Okay. Because those were about the same too. So I was surprised, like rates of interstitial lung disease actually comparable between the two groups, rates of malignancy comparable between the two groups. It was really this with the misdiagnosed patients. That's where you saw the issues with the lung disease. So it was worse in those patients when it was diagnosed.
Well, so it's an interesting thing to me because this is one of the more frequent diagnoses that would end up getting referred for patch testing. So I got pretty good at diagnosing what I would call skin-only dermatomyositis. So I guess the patent right type, because the people that I see with dermato, and I probably would get 2 or 3 a year, so probably 20 or 30 of them. None of them ever had any lung disease. None of them ever had anything. It was just, but it was very obvious, sort of cutaneous. They would have Gottron's papules, and they would have the streaking over the tendons and the upper back and the scalp and all that stuff. And I'd put them on some mycophenolate or some methotrexate, and it would work great. And I just felt bad for them because they would go, 3 years of, by people suspecting stuff. The biopsy would not show anything. People would order labs and ANAs and it wouldn't show anything. And so there was never like a diagnostic test. And I also wonder, like, hell, maybe I was wrong when I said they had dermatomyositis and it really was just, rash. But it's such an interesting disease because there are so many patients who just have no anything other than a rash and itching, and no labs, no biopsies that diagnose it. You just have to make the call on your own. Those people are interesting to me.
Yeah. It's a really uncomfortable disease. I feel bad for them. It's like a very, uncomfortable, itchy rash. Yeah.
The last patient I saw with this paper reminded me of, it was just like within the last couple months, and she had interface dermatitis, and I just wasn't quite sure. She had horrible lung disease.
Huh. Yeah. So the point of this paper was basically that the longer they go misdiagnosed, the more sort of progression there can be of the non-skin disease aspects of it. It wasn't a whole lot about how do you avoid misdiagnosing them.
No, right. They didn't really get much into how do we avoid this? Do
better. That's it. Do better.
It's always got to be in the different. I mean, that's what I think about DM is I probably am not as good as I should be as putting that in my derm NOS, or what could this possibly be? I certainly missed it with that woman. Fortunately, like, she had 1 day of misdiagnosis by me because she saw a rheumatologist the very same day she saw me, and he emailed me and he's like, I'm pretty sure this is DM. And I'm like, oh gosh, yeah. And she did have like one of the myositis markers, one of the Oklahoma panel myositis markers that was elevated, and she had bad interstitial lung disease.
Okay.
I think fortunately why they pushed you out of Hopkins now.
I graduated with honors. Maybe let's just say I graduated.
Wait, they have a satellite campus?
The Erie. Johns Hopkins Erie.
All right. Are we done? Okay.
All right, we're jumping over to my first paper. which this one to me is a huge game changer. So basically, the title here: effectiveness, tolerability, and safety of topical clobetasol with oral hydroxychloroquine versus topical clobetasol with narrowband UVB in unstable vitiligo. Investigator-blinded, randomized, controlled trial. So small numbers. The groups were not well randomized, meaning there were significant baseline differences. The people who got hydroxychloroquine did not have as severe disease. Their disease was, so meaning they had less vitiligo and they had it for less time. That was just the way randomization sometimes plays out with small numbers. There were 35 people in the narrowband clobetasol group, 39 people in the hydroxychloroquine clobetasol group. Relatively short study, 6 months. But the main takeaway was that hydroxychloroquine, even at a low dose, really made a difference. So the hydroxychloroquine group, whenever they tried to control for baseline severity, did substantially better. So the hydroxychloroquine group improved close to 50% whenever they adjusted everything. The narrowband UVB group improved more like 15 to 20%. Now, they weren't doing great narrowband UVB. It was only twice a week for 6 months. And so, I usually think of narrowband as working a good bit better if you can get in there 3 times a week at least. And so they said that their results with narrowband weren't as good as other studies because of the lower frequency. But the main takeaways, it never freaking occurred to me that hydroxychloroquine might help with vitiligo. There's not anything else in the literature suggesting this. They went through some mechanistic things where there is some molecular data in cell culture of why this should work. But it really, until we get JAK inhibitors approved for generalized vitiligo, this to me is now the first reasonable oral treatment we've got. And low-dose hydroxychloroquine, incredibly safe, right? So your risk of retinal toxicity at 200 milligrams once a day is pretty minimal. Becomes something now where in the past, when I would have said to a patient with widespread vitiligo, like, here's some Opzelura for your face, for the rest of your body, sorry. Now I'm going to be, here's some Opzelura for your face, some clobetasol for the rest of your body, and I'm going to put you on hydroxychloroquine, 200 milligrams once a day. Really is going to kind of change the way that I approach sort of widespread-ish vitiligo. So thoughts from you guys?
Curious if it works without the narrow band.
No. So they did it without, so it was either hydroxychloroquine and clobetasol versus narrowband and clobetasol.
Oh, sorry. I missed that. I thought that
both
got narrowband and it was the other.
Nope. Okay. So they got either narrowband or hydroxychloroquine, and the hydroxychloroquine people did a little bit better, but they were very unmatched at baseline.
Gotcha. Okay.
Pat, any thoughts?
No, I mean, right? That's an easy treatment. I'm doing it my next vitiligo patient.
Right. It's
I'm
cheap.
Committing to it.
Dirt cheap, very safe.
Yeah.
And I'm interested what you guys do whenever you start hydroxychloroquine. So I typically, as long as they've seen an eye doctor in the last few years, I usually don't get a baseline optho. I put them on the hydroxychloroquine, give them like 3 months, and then if it seems like it's working, I'll send them to optho. Because I'm like, until I see if it's doing anything, why bother? Because I can't think of any reason why you need a baseline. There's no acute ocular toxicity with it, and it's not going to do any. You're not going to have any issues in the first 3 months. But standard of care is to get one at baseline before you start the hydroxychloroquine. What do you guys do? Is it
still standard of care to get it before you start? I thought it was saying like in the first 6 months, or there was like those guidelines have changed. I thought I do not do it before I start. I start, and I agree. Yeah,
I am the same way. I don't get a baseline. I tell them to get it within the first 3 months.
Damn it! I thought I was being edgy.
No, not.
You are edgy, man. Don't ever. Don't sell yourself.
All right, let's go to our next article here. Dr. Ferris, what do you got?
Okay, Matt, I picked this one because I was like, you're gonna love this so much. Because you could tie it back in some way or form to Dupixent. So there you go. So
In a good
um,
way.
in a good way, yes. Skin damage signals mediate allergic sensitization to spatially unlinked antigen, which would seem like, what is that? So this is Weisman et al. In Science Immunology. So this was, they used a mouse model basically to show that if you have injured skin, that you will have that you can have an allergic reaction to something that you get exposed to in the gut. Okay, so what they did was they had, they said, basically, oh, we know there's this skin gut connection, right? So you got, food allergy and AD and, IBD, and you can have, PG or,
Yeah.
psoriasis and arthritis and, all like that, skin disease is systemic. So, they had this hypothesis that basically having damaged skin could have this adjuvant effect and sort of skew the immune response to something you get exposed to in the gut. So in the non-inflamed gut. So what to test this, what they did was they said, all right, we're going to just tape strip the skin of mice, and then we're going to do oral gavage, like basically where you force feed them ovalbumin.
Okay.
And they said that is sufficient to get allergy associated anti-ovalbumin antibodies, IgG1 and IgE, but not those that are associated with like protective immunity like IgM, IgG2B.
Hmm.
And they also like got this anaphylactic response. So apparently mouse anaphylaxis is like you eat something and your temperature drops. So you can actually measure it. So they actually could introduce that. So that was kind of cool, but you're like, all right, tape stripping. What other forms of skin injury? They did like a punch biopsy to injure the skin, same thing. Chemical ulceration by intradermal acetone injection, same thing. High dose UV radiation, same thing. All right, well, maybe it's like ovalbumin, right? I mean, who's eating ovalbumin? So they did peanut allergens, same thing. And you're like, maybe it's the microbiome, maybe it messed up the gut. They did it in like specific pathogen-free, germ-free, mouse colonies who don't have like, a microbiome, same thing. Then they like depleted secondary lymphoid organs, basically like things like tonsils and lymph nodes. That those mice did not get it. So what they said, and like there's a ton of
Yeah.
science that I am not going to go into because it's complicated, and it's been a long time since I was at the Johns Hopkins University studying immunology. So I feel
Hey,
like
I went there. I went there too.
I heard that. I heard they didn't let you stay that long. No, but it was so key cytokines: IL-33, TSLP, IL-1 beta, and IL-18. But there was also like, roles for IL-4 and IL-13 for skewing IgE production. Like if you basically like, if you got the exposed to allergen, IL-4 and IL-13 were key in sort of skewing that to being like an IgE response, which would be associated with the food allergy anaphylaxis response. So
Mhm.
they said IL-33 and TSLP, they're alarmins, which are like things that tell your immune system, like, whoa, be worried, there's something bad going on, think about like responding to this. And it's definitely, complicated, but I thought that was fascinating. IL-33, not a cytokine I think about a lot, but it can prime tissue environments, to cause accumulation of like intestinal mast cells, eosinophils, innate lymphoid cells, type 2. So it's sort of like this type 2 immunity story. And that was like enough to have the like to sort of enable this threshold where you would actually get anaphylaxis. So the other thing that was interesting is you had to be getting like the allergen for the first time. So if the mouse had ovalbumin to eat when it was like fine and the skin was
Mhm.
fine,
Mhm.
and then you went back and tape stripped or whatever, acetone ulcerated them, and then gave them ovalbumin again, they're fine. So it's like there's this innate, this like unique window. So, what do I think? I mean, I thought this was super interesting. I like the skin gut connection thing, which I sometimes think is BS when patients talk about it, but now I'm like, maybe there is something. But, what about this like link to food allergies in patients with AD and this like atopic march idea, right? So,
Yeah.
and we now
So
tell people like, if you're going to give your, expose your kids early to peanut butter, to peanuts, or, maybe we should think in kids who have atopic dermatitis, think about those super, and now this is all hypothesis, there's nothing in there, but like, think about those allergenic foods, like, peanuts. Think about egg, think about, I don't know, like seafood. And maybe say, if you've got a kid who's got AD, like, don't, if you're going to try to do this oral tolerance where you expose them early, like avoid those things when they're in the middle of a bad AD flare. Like maybe the time to expose is not when you've got bad, skin disease. Or maybe like, I don't know, if your kid
yeah.
like got a horrible sunburn, don't give them their peanut for the first time.
So this is really, I may be admitting I'm wrong about something, or at least I have to think about it differently now.
Don't do it, Matt.
So we've known for a long time that where you get introduced to an antigen is very important. So if you get transmucosal exposure initially, you become anergic, so actively desensitized. And if you get transcutaneous exposure of antigens, you get sensitized. So you develop IgE and sensitization. And so the belief has been that the reason that kids with AD get food allergy is because they've got an impaired skin barrier and they're smearing food on their skin before they became desensitized. And then whenever they hit 5, the reason why food allergy goes away is because they're no longer getting food on their skin. They're only getting it in their gut. But then that kind of begged the question, well, why doesn't it go away in all of them? And why doesn't it go away completely? And why doesn't it whatever? And this may be the other part of that answer, that the systemic, this is, again, just fascinating because I always think about with nickel allergy, if you ingest enough nickel, we can measure that you get IL-5 and IL-10 released from your intestinal lymphoid tissue, and that can drive a rash. I never really bought or thought about that a rash driving intestinal immune changes. And that is interesting. That is really interesting. I'm not sure what to do about it yet or what it changes, because it gets back to, because what I was initially thinking was like, are the mice like you're forcing it down their throat with the gavage and then they're puking it back up and like rolling around in it? Maybe that's
it's interesting. They did, so like there's a lot of like controlled things within this paper. So they did say like, oh, if you get foot pad injection, you can induce it. But, they also did this in ways like where they would just give it in the stomach, and they made sure that they didn't ever put them, like you would have a mouse, like you could have a mouse who was in a cage, mouse A got the ovalbumin exposure and mouse B did not. And, only the one who got the oral exposure actually had the reaction, because they were like, well, what if it's like in their, mouse droppings, or they're throwing it up and it's just hitting the skin? Then it should be that the mouse who was in the cage but didn't get it orally should also be getting.
As per Dr. Kaplan, they all needed cones of shame.
Exactly. Yeah. So, I thought this was, it was like an elegantly done study. Look it up if you are interested in this kind of stuff. They do knockout mice of this and inhibiting that. And like, there's a lot more to this than my very simplistic, 6-pack review, but super interesting stuff.
Okay. Cool. Patton, you got anything else? You ready to move on to your next article?
Yeah, no, I don't understand anything she just said.
Johns Hopkins, you understood that.
My second 6-pack, JAMA Derm, published online April 2025, titled Epitope Spreading and Immune Checkpoint Inhibitor Associated Bullous Pemphigoid by Koga et al. I like the title. It turned out to be a case report. It's kind of lame for me to do a case report, but it's getting late in our 6-pack. I'm already 5 beers in. This was a case report that described an 80-something-year-old patient. I actually had that in the article. 80-something. Like, Really? You didn't?
Yeah, look at you said like ninth decade, a patient in the ninth
Yeah.
decade. Yeah.
So it described an 80-something-year-old patient with lung adenocarcinoma that developed bulla after 10 months of Nevo therapy, diagnosed with BP, eventually died of her lung cancer. But the authors had her sera banked. And so they looked at her sera at the time of immune checkpoint inhibitor initiation. So prior to ICI therapy, the patient had antibodies to the C-terminus portion of the BP antibody, right? We think of NC16A as being the pathogenic target for antibodies. This was at the other end of the BP180 molecule. So that's where she started. And then when she developed BP, of course, she had a pretty high titer of the NC16A, antibodies to the NC16A portion. She had antibodies to the BP230 antigen. And yeah, she had some other epitopes on the BP180 molecule. So it was just kind of a new thing of, they brought up the idea, maybe we do screen these Nevo, these ICI patients. Now, granted, doing an assay where you can detect antibodies to the C-terminus, that is not like widely commercially available. But basically this neat article, and she had 7 years of pruritus before she got. So they kind of, theory, hand waving, the antibodies to the C-terminus, that's what caused the pruritus. When she got the Nevo epitope spreading, she developed antibodies against the other antigens and then developed clinical BP. That's it. I mean, I thought it was kind of cool. What do you guys think?
It is fascinating to me, these, the checkpoint inhibitors. I feel like we're learning a lot more about sort of immune stuff in general, but it's like a natural experiment of seeing what the hell happens whenever you just make people's immune systems go nuts. Like it's an and this kind of falls into that category for me.
Yeah, I think it's interesting. I mean, that you have a little pre-existing autoimmunity, but we can control it, and then you take the brakes off, and it's like, oh, now it goes crazy. Yeah.
We did this with one patient. One of the oncologists said, I have this banked serum. It was a patient who developed BP after immune checkpoint inhibitor therapy, and we actually did the BP 180 ELISA, which most of the commercial tests are specifically to that NC16A portion. Her titers were positive at the initiation. She did not have clinical disease. And right, I mean, you think about this, that's an easy screening test to do, right? BP ELISAs at the baseline of therapy. Now, I mean, what would you do? Watch them more closely? I mean, I don't know if there's any practical treatment we could do. Put them on doxy.
Pre-treat them with clobetasol, like for the other ones that we talked about.
I put them all on nicotinamide.
There we go.
Yeah, the Vedotin
something.
And Fortimab Vedotin.
There we go. But just like the pre-clobetasol helps, right? Okay.
Yeah.
All right, we're moving on to our last six-pack article, and this is a trio, which is designed to make a point. And so the article,
you just made it a 10.
What? So yes, you're true. I made it a 9-pack. So the article that got me started with this, the impact of the menstrual cycle on exacerbations of atopic dermatitis, a systematic review. So basically they, did a big literature search, and the summary is that about half, somewhere between a third and a half of women with atopic dermatitis will reasonably consistently experience a premenstrual flare. So kind of typically starting about 7 to 10 days before menstruation is going to start, they will experience a flare of their atopic dermatitis. And there's a lot of theories about, why, right? So estrogen and progesterone are hormones that have immunologic effects. They also, especially progesterone, has some effects on skin barrier permeability. So the mechanisms of this are not terribly well worked out, but it is pretty well established at this point that premenstrual flares are not rare in atopic dermatitis. And they also looked at psoriasis as kind of a comparator and said, no, there's no real premenstrual changing of psoriasis. But the that reminded me of an article from 20 years ago. When was this? Yeah, 20 years ago, 2005. So this was back whenever I was just getting into patch testing and contact dermatitis. And it turns out that at least for nickel, when you patch test somebody, at what point in their menstrual cycle makes a huge difference. So I don't want to say a huge difference, but if you the way that they did this study, this was nickel contact allergy in the menstrual cycle. They got 30 women who were allergic to nickel. They repeated patch testing. So normally you're patch testing to 5% nickel. They did instead these dilution series where they did, progressively lower concentrations of nickel. And then you can patch test people to it and see what's the lowest concentration they react to. And the idea is the lower the concentration they react to, the more sensitive they are. And what they found whenever they did this was that, and so half of the women they tested first at mid-cycle, and then second premenstrually, and then the other group they tested first premenstrually, then second at mid-cycle. And basically they showed that you are much more sensitive to nickel whenever you are premenstrual. But then so now we know that both allergic contact dermatitis and atopic dermatitis, and whether that applies to all allergens or it's just nickel, we don't know for sure. Nobody's ever done that study. I actually recommended to the North American Contact Dermatitis Group at one point that we start asking all of our, female patients at what point in their menstrual cycle are they, while we were patch testing them. And the basic response was, we don't want to ask. So we never added it. So we don't know if this applies to any other contact allergens. But the big takeaway is I would get so many referrals over the years, kind of like for dermatomyositis, for autoimmune progesterone dermatitis. And the main thing that I want to say to all of our listeners, you are never going to see a case of autoimmune progesterone dermatitis. So if it crosses your mind, you should be like, okay, this is either atopic dermatitis or allergic contact dermatitis, because autoimmune progesterone dermatitis, in the most recent big review I was able to find, there were a total of 89 patients reported in the history of the world who had confirmed autoimmune progesterone dermatitis. And a substantial number of them, I actually think it was probably just atopic dermatitis that was flaring premenstrually. Because people like to do this, people would send to me to do intradermal progesterone tests. And the problem with the intradermal progesterone tests, there's no instances of hey, let's just do this to 1,000 people and see, does it trigger does it trigger just 10% of people who have a positive, we have no negative control for, so if you ever think you have autoimmune progesterone dermatitis, do not send them to your local patch tester. Talk if you really, really think you've got it. So meaning either they have a non-spongiotic path. So if it's interface or it's urticaria, different, that is more consistent with autoimmune progesterone dermatitis. If you're reasonably convinced, get in touch with their OBGYN. The real way to diagnose it, because what's the use of diagnosing it if you don't have a therapy in mind? The real way to diagnose it is get somebody on one of the GnRH, the gonadotropin-releasing hormone agonists or antagonists. They both completely get rid of progesterone and estrogen for 6 months. And if their rash completely goes away, then, oh my God, it is autoimmune progesterone dermatitis. And then the question is, do you want to get your ovaries taken out to get rid of it? Where you could also stay on the GnRH forever, but there are a lot of potential side effects with that. If it doesn't go away completely, then it's not autoimmune progesterone dermatitis. But when you see premenstrual flaring of a dermatologic disease, your first thought should not be APD, autoimmune progesterone dermatitis. It should be atopic dermatitis and contact dermatitis. We know that both of those diseases flare premenstrually, but people love to just immediately, when a woman comes in and says, oh, it seems like it always flares right before I have my period, oh my God, you might have autoimmune progesterone dermatitis and the blah, blah. They don't have autoimmune progesterone dermatitis. Wow. It is incredibly unlikely. Much more likely it's just AD or contact derm that is flaring due to the hormonal fluctuation.
What was the nickel study? I mean, would they not react to it at all at certain points in their menstrual cycle?
Yeah,
or just it wasn't as bad?
that's the interesting, and I don't know that so like what they did in all of this was showed the minimal eliciting concentration, and they basically showed that it went up or down usually by one or two things, but there were a few people who so usually the 5% is such a high concentration that like regardless of where you are in your cycle, you're going to respond anyways. But there were a few people who did not respond in their ovulatory phase, kind of mid-cycle, but did respond to the 5% in their progestinic phase. And so it is theoretically possible that you could miss contact derm depending on when in somebody's menstrual cycle you patch tested them. Like it's that probably does happen, but how frequently it like this, because patch testing is, again, it's notoriously non-reproducible for 1+ reactions. You probably have a 50 to 70% reproducibility, which is terrible. Part of that reproducibility might be related to things like menstrual cycle, how much stress somebody's been under, blah, blah, blah. But we don't really know. Like it remains a bit of a black box, but the big takeaway was you're never going to see a case of autoimmune progesterone dermatitis. It is extremely unlikely. And now I know that next episode you're both going to come back and be like, well, last week I saw somebody with autoimmune progesterone. God damn it.
I'm going to have a case series of 13 women. They're going to be on the show with me.
I don't know if they'll fit up there in your little low ceiling room. We'll see.
Yeah, come up to my attic. No, thank you.
It'll then be a podcast of 2.
Well, we could maybe smuggle something into Pat in prison.
That's right.
Might work.
All right. Well, on that one, that's why we don't give you 9 beers.
I'll be off at 6.
Cut them off. Well, I want to thank everybody for joining us today. I hope that you found some of these articles useful. I hope you laughed once or twice. I hope you learned a thing or two, but mostly I hope you're going to join us again next week. And until then, I'm Matt Cyrus.
I'm Tim Patton.
And I'm Laura Ferris, and we are Derms on Drugs.